I wanted to first say welcome to those who are unfamiliar. This is Harvard and Tech and the COVID Foundation's webinar on contact tracing technology. And for those of you who are unfamiliar with Harvard and Tech, we're the official alumni group for technologists, and Harvard recognizes us to put on events throughout the country. We have chapters in San Francisco, Japan, Seattle, New York. Obviously now we're all online, but this webinar has really brought us together and to talk about some really interesting technology that Jonathan will elaborate on. But in conjunction with Harvard and Tech, the COVID Foundation is a group of people that, from Harvard also started a foundation, 501c3, to contribute to first responders. And I know some of you are first responders, so with that we say thank you so much for everything you're doing. You're incredible. You're the health heroes. We provided PPE and other goods to frontline workers from the very beginning and are continuing to do so, as well as reaching out to communities that Jonathan will talk about, that are really getting hit hard with COVID at this moment. So this topic is really dear to, the COVID Foundation and Harvard and Tech, just because we've been wanting to get involved and contribute and give back as much as we possibly can. So with that, Harvard and Tech COVID Foundation, please let us know if there's any way we can help you. This is as much about you as it is about, us learning as well from what you need. The website for COVID Foundation is covid.cm, and you can learn more there. Harvard and Tech is just harvardandtech.com. So with that, I'll give an introduction to Jonathan. Jonathan Feit is co-founder and CEO of Beyond Lucid Technologies, a software company that connects ambulances and hospitals prior to the patient's arrival and documents patients' mobile medical care over time. He's also managing consultant of the Brain Trust of Fire and EMS Technologies. Jonathan has presented and delivered posters to over a dozen national and international healthcare conferences on topics ranging from community paramedicine and trauma to artificial intelligence in disaster response. At Beyond Lucid Technologies, Jonathan has negotiated collaborations with major multinational corporations, including Dell, Lockheed Martin, Athena Health, among others. BLT's software connects nearly 200 hospitals to the MediView Beacon pre-hospital health information exchange and operates in specialized but very large niches of care, including readmission avoidance and intervention on behalf of patients with substance use disorders. So with that, I'm going to turn it over to Jonathan, and he will be explaining, all about contact tracing and, the technology that is being used right now to stop the spread of COVID.
So thank you very much for having me. Thank you to everybody who's attending. And since I know we'll send this out later to anyone who can't make it today, the up and the down, I suppose, of being in the mobile medical business is schedules change on a dime. Calendars quickly become meaningless, especially during a crisis. So for anyone who watches later, certainly appreciate the time and interest in this topic. I'm going to try to take today's conversation and make it less about what my organization is doing, although there's probably going to be some of that comes through here. There will be some of that comes through here, but really about the topic of contact tracing and why spreadsheets aren't enough. And I think that's an important, hopefully, takeaway that you're not only going to hear from me, but time allotted, you're actually going to hear from the COVID coordinator for the Los Angeles County Fire Department, Terrence McGregor, who we've had the pleasure, honor of working with in a pretty remarkable, I think, case study of innovation in real time. And so we're really going to talk about what is happening now with this concept of COVID as catalyst. And those aren't my words. I was attending another webinar, as everybody here is attending, webinars like crazy, a couple weeks ago, and somebody called COVID-19 the great accelerator. And I thought that was really a remarkable truism, because there is so much happening right now. And on the one hand, and this really is a fascinating dichotomy. On the one hand, people are terrified, not just in mobile medicine and public health and public safety, but really across, I think, a lot of different ecosystems. They're terrified about doing more than they need to, right? So we were just talking about a few minutes ago as a prelude, making sure that if they're going to invest in solutions or in process changes or in people, in whatever you need to do, that you're doing it the right way, right? That you're doing it right now, but you're doing it the right way. And so you're kind of trying to time the market. And, I don't think you have to go to Harvard to learn that timing the market is not necessarily the wisest idea to do, whether in finance or in public health. Because by the time the wave shows up at your door, it's probably too late. On the other hand, you don't want to invest in the wrong things. And so people are taking, they're on the lookout, but they're taking their time to try to find what's out there. And at the same time, the crisis is continuing. So you end up with this dichotomy of trying to figure out what's the right thing to do and what's not too much to do. Speaking of Harvard, by the way, just my little Easter egg nod to you guys. Don't know if Dustin Hoffman, in fact, went to Harvard, but hopefully everybody recognizes this shot from what has become one of the most popular movies of the year, I believe, a throwback, Outbreak. Great movie, by the way. So again, I think that's what we're going to try to go through. And so I try to use other people's words more than mine whenever possible. And this right here is a tweet, actually, that just went out from Dr. Antevi, who everybody in the mobile medicine world, I think, knows. He is highly regarded, certainly highly deserved the regards that he gets, medical director from Southern Florida. So he is the EMS medical director for Coral Springs, Davie, Southwest Ranches, and American Ambulance, as well as other associate medical director roles. And he talked about how he's getting calls from schools, businesses, and friends trying to figure out what the heck to do. He also has been remarkably forward in terms of his own experience doing blood testing and sort of walking the public through the experience of trying to get a contact tracing process done with him included. So again, it's really highlighted for me the idea that it's not just folks in fire or emergency medical services or in emergency medical transportation who are interested in this. And it's not just public health, and it's not just hospitals, and it's not just politicians. There is really an entire range of participants trying to figure out, what do we do? And so I'm kind of going to give you the punchline of my presentation first here. And ask you to think about what distinguishes, when it comes to contact tracing, when it comes to exposures, what distinguishes Los Angeles County Fire from an Amazon warehouse in New York City, from a pork processing or other meat processing facility in Nebraska or Kansas or Iowa, Missouri, from a Tesla plant in the San Francisco Bay Area, or for Delta Airlines. And these, you might imagine, are not random. All of these entities have been in the news lately with respect to their own challenges dealing with exposures to COVID-19, suspected, confirmed contact tracing. What happens if one of your passengers turns out to have been confirmed infected, and what do you need to do next? So with that, I'm gonna start again. I'm kind of going to invert this presentation a little bit. At the end, I'm going to talk about sort of the how we do things. But for all those who know me, know that I am generally, both as an entrepreneur and as an interested person, far more focused on the why. Whether it's a mission, whether it's a purpose, a vocation, call it what you want, the why and the timing and the what we're doing and how all of this will ultimately translate into things that matter for people is really what I want to focus on here. So I'm going to invert this presentation and talk about how I believe there's a moment now, right now, to share information not only across mobile medicine, but also our allies. And when I say our allies, I'm talking about the full range of participants in what once upon a time, but I am part of a group trying to move this away from the conversation of pre-hospital care, because at the end of the day, the guys and women with the trucks with the sirens and the light bars, they might transport to a facility, but ultimately they're responsible for taking care of so much of what happens once patients leave a hospital too. So knowing whose house they're going into, there's a whole range of participants in this, and it also includes public health, it includes academia, it includes businesses, it includes politicians and lawyers and so on. And so there's an opportunity for us to make an impact now that we can measure. So it's really not just the idea of there's a disease out there. Oh, by the way, media is a huge part of this as well. I've spent a significant portion of my career in media, so I think media needs to be both looked at as both a conduit for help and also a significant part of the problem right now, as we'll talk about. So we have the opportunity to make an impact, but this but is so big that I kind of wanted it to occupy its own slide here. There's an enormous amount of skepticism and for good reason. And again, I think since I just mentioned media, I'm going to pick on this Apple Google contact tracing, and I'm going to call it a PR stunt, and I'm going to do it on purpose. And I know that can piss off some people, and I don't care, because this is a really, really, really big problem. The topic of contact tracing using a cell phone in the United States is virtually impossible. Because, quite frankly, and very, very simply, phones don't have access to electronic health records. There are countries in which that is theoretically possible, where we have nationalized health systems and so on. We don't have that in this country. So to the degree that there was this massive discussion in places like, well, all kinds of news media around Bluetooth and bump type technologies, and if you walk by somebody, you're going to know who they are, it's absolute hogwash. That's simply what it is, and I would challenge anybody who says otherwise to prove to me how they are going to get that information without the individual patient reporting their own condition. And considering that most patients aren't great about self-reporting their illnesses, if they were, we wouldn't have so many emergency medical service entities in this country. Without a sense of what's possible and without a sense of what's real, it all becomes noise. And again, I think it's probably worth showing these again, coming back and having everyone dig into these. They are a range of trade publications, business publications, popular news media, pop culture media. And some folks are starting to realize that there's a challenge when we can't tell what's real anymore. We are trying to innovate in real time. We are trying to find solutions to a pandemic in real time, recognizing that there will also be something next, right? So COVID-19, unless COVID-19 becomes the last illness that the entire world ever experiences, maybe there's an asteroid I don't know about or something along those lines, there will be a COVID-20 or 21 or 22. There will be flu that shows up in September. There will be other things. We have always, as a society of animals, we deal with things making us sick from time to time. It's incredibly important that we understand what's real, what's possible, what's not, and be able to deposit our resources and focus them in ways that are going to make things better. But because most of the people, I would argue probably most of the people on this on this webinar, let alone in this country, certainly in Washington, are not technologists, and most of them aren't public health professionals. It can be very hard, and I empathize with them, to try to make the best decisions with a limited amount of understanding of how to tell the truth. And so in the absence of that, this is most people's innovation. In the entrepreneurial community, especially for top technology, there is an old phrase that goes, nobody ever got fired for hiring IBM, right? Show of hands if you ever heard that. That's a bit of an old phrase, but the point is what it is. If you go with the tried and true, or the devil that you know, or whatever phrase you want, you end up with the same thing we've always had, which is things like spreadsheets and pieces of paper, that old standby. I remember years ago when I asked someone in the mobile medical business out here in California what they do. They had a web-based patient record system that they were using, and I said, what do you do when the computer goes down and there's no network connection? And he said, we go back to what we've done before, which is basically a chisel and a slab. He was only half joking, right? Paper is that old standby. And so in the absence of being able to tell what's real, people tend to go back to what they know. The problem is they quickly get overwhelmed. And this actually is a part of a quote from an agency that we have had the pleasure of working with, describing why they went to work with us. This idea that if you have way too many is what he said. This was a department chief, and the idea that at some point you maximize your ability to utilize those old school resources, or you have to dedicate so much in terms of human capital and personnel time that you're taking away from what you really need to be doing. So these are the types of environments where technology can really shine. The problem is that we all have this really, really compelling competitor. And we need to think about that. Again, when I was starting my company, people would ask me, investors in particular, would ask who our competitors are. And of course, there's that, it's sort of a trick question, because entrepreneurs like to think that they're always the first and the most innovative and so on. And the answer, if you ever say we don't have any competitors, you're politely asked to leave the room, because everybody has a competitor. At the very least, the competitor is whatever whatever came in the absence of technology, right? Whatever it was before. In our case, my strongest competitor is a piece of paper. It's that old standby. So the absence of anything new, simply doing what we've always done, is that inertia effect is a remarkable hindrance when it comes to something we've never seen before. Because sometimes you need inertia, you need that innovation. You have that new perspective, and that's where I think, again, when for all the geeks on the call here, inertia is overcome by force, right? That force is lowered by a catalyst. It's the definition of a catalyst. And so to me, that's really what COVID has emerged as being. And it's a very, very compelling way of looking at this crisis that we're dealing with is grease in the gears. It is providing an impetus. It's providing a stimulus. It's providing that force to overcome that which we've always done and realize that there really might be a before COVID, after COVID world. My mother seems to think that America's never going back to the way it was. I don't know that we're quite there, but I think there are some things that will never be the same, right? The idea of telework has been demonstrated to be real, for example. And so I really want to encourage this idea that if we leverage this opportunity and we take a challenge and we turn it into an opportunity, that not only do we have the ability to flatten the infection curve, slow the spread of this virus that will mutate, by the way. So COVID-19 is not its be-all end-all, it's already changing, and there will be things that come next, but we have the ability as managers to protect our people, and perhaps most importantly, beyond the people themselves, to enable the organizations to make wise decisions. And one of the fellows on this call, I won't say who it is, but he and I had this conversation very early on in this crisis, where we talked about one of the guaranteed outcomes of the COVID-19 experience, which is lawsuits. Lawsuits will emerge. There will be people challenging decisions about why you sent somebody home, and when you did, because they really want to be at work because they need the money. And there will be lawsuits challenging those who didn't get sent home fast enough, and therefore had the opportunity to make their colleagues ill. That's already happening. We're seeing that at Amazon in New York. We're seeing it in other places. So the organizations are, by definition, afraid of getting sued and being told that they made bad decisions, even if they didn't make bad decisions. So a huge part of what I see as the mandate that I have, my organization, I often say, we're not a medical device. The people that we serve are the medical device. It's our job to empower the mobile medical professionals to do their jobs. But so much of the time that job consists of enabling you to justify what you did, to support the decisions that you made, to be able to convey to others why you, in the moment when you were dealing with what you were dealing with, decided to do something. And hopefully that was wise, but one way or another, you have context for that decision, because that is where the snapshots of media that we're hearing right now are really not doing anybody any favors. Everybody here and everybody watching understands that it's a moving target. And so being able to contextualize why you did what you did at the time with the knowledge that we have at that moment is really what my mandate is about. And so I think to the degree that people can realize that there are those of us taking that approach, this is less about what your people you do on their own phone and about your ability to help them point in the right direction. And I mentioned the word empathy before. So to me, as an innovator, as an entrepreneur, I am fascinated by what we're going through right now, because we are really dealing with real-time innovation. And that's something that you only get to deal with if you're lucky a couple times in a career. I mean, imagine how exciting it would have been to be working somewhere in the aviation industry when the Wright brothers were taking off, right? I mean, you're really talking about the possibility for something being dramatically changed. But what's so unique now is that innovation is all about understanding what the needs are and meeting them. We're being told what that is, or what those needs are, by the end users who are ultimately going to use them. People saying, for example, there's not enough time in a day to do all the contact tracing, but I absolutely need to do it. So now you have an opportunity to address that. And what I'm going to highlight in this presentation is how those bottom-up cases came to be. Folks who felt comfortable and felt compelled to speak up about what their needs were. So, one of the things that I often find myself talking about is that, especially, and this is why I find so much passion for mobile medicine, but again, there's an analogy for this in other industries as well, is that no matter whether you're large or small, you are your community's most important resource, particularly during a crisis. And one of the things that we are finding now as the wave crescendos and it moves is the places, particularly the rural environments, the small towns, the places that are not as resourced as Los Angeles, New York, Chicago, Houston, etc., are starting to find this crisis on their doorstep. And that phrase, ironically, came from an agency in Houston, which called me a couple weeks ago on a Saturday and said that thing we were waiting for finally showed up on our doorstep. So the idea that if you listen to what these users are telling you that they're going to need, you can bend to address it. And so to me, that's really a huge takeaway, and I hope you guys find this really, really exciting, because we do. We had a real-time innovation, and in some cases, between bedfellows that would otherwise not have an opportunity to meet one another. As an example, we're going to talk about my organization, Beyond Lucid Technologies, which by personnel is one of the smallest in our industry. We only have 4 people on our team. Incidentally, we are hiring, so if anybody out there knows, we've got 1 or 2 open slots, and if anybody knows somebody amazing that we should talk to, please do hit me up afterwards. But the Los Angeles County Fire Department and Harris County's emergency medical ecosystem these are among the largest organizations in the country and in the world. And so to the idea that these strange bedfellows could not only talk to one another, but benefit one another and have success stories and numbers to talk about that is truly remarkable. I don't care whether you're in this industry or you're an outside person watching innovation happen. It doesn't usually happen this quickly. And so that is really, really an exciting adjunct of everything that we're dealing with. It sort of underscores why my organization has an interest in this. We've been called, I'm very proud to say, Silicon Valley's emergency medical technology experts, and work in large and small communities across the country, which gives us a purview to be able to see clusters. And so this is really, it's something that jumped out at us as we were watching the data, and we could, you see about 25% or so of the organizations I work with are rural. So we had an opportunity to sort of see what they were doing and what they weren't doing, and to watch the spread move. I noted here, and I wish more people would talk about it, that there's been an interesting alignment of the density of infections around international airports. That's different than, for example, SARS or MERS from a number of years ago. If we have that kind of information and we can dig into what that means from the data, and we can make the data available, then we have the opportunity to make smart decisions. And so, for example, the Rico Fire Department is Rico Medical and Fire District, the proper name, is one that I'm going to highlight a little bit here when we talk about how they're sharing their data and enabling that information to be accessed by others who need to in turn use it to make their own decisions. So I'm going to take this quick step back because a big topic of conversation in our industry has been the overlay of one crisis to another. Of course, September 11th, 2001 doesn't need much of any introduction, but this is Times Square on the right in 2020, and that's very interesting. In fact, I really, really want to go to New York just to see this. I didn't, but I would have loved to have been there to experience this post-apocalyptic moment. And yet, some folks have lamented that things are going to go back to the way they were in our industry, for example. I don't know that I agree with that. Because in 2001, while emergency responders and mobile medical professionals got some moment in the sun, it was fairly fleeting. It was, there was a moment in time, it was a crisis, and they responded, and unfortunately, tragically, many of them were forgotten. Now it's different. this is prolonged. And so the role and risk that mobile medical professionals have put on themselves has really become, I think, part of our national zeitgeist at this moment. There is an understanding that folks are putting themselves in harm's way to care for others who are unable to care for themselves, and that doesn't necessarily mean they're even necessarily doing it while they're alive. Getting called after the fact, as we are seeing in those rural communities in places like Oklahoma, there is to put it kindly, there is a concern that once the panic dies down, there will be a smell of death that is palpable across this country because people didn't leave their homes. The number of substance use cases has skyrocketed in communities across the country, but certainly those that don't have local assistance. People are afraid to go to the doctor. Even friends of mine are afraid to go to the doctor, even despite everything that I get to talk to them about how important it is to get the care that you need. And so they are staying at home, and at some point loved ones are saying, we haven't heard from Mrs. Jones in a while, we should go check on them. And they are finding that she's sitting in the same chair that she was for the last few days, but no longer with us. And so there is really a change, I think, happening. And our industry, it has, on the one hand, seemed that we have a species problem. Fire versus EMS, public versus private, hospital versus everybody else. That is a long-standing problem in our industry, and yet this concept of archipelagos, the screenshot on the left is an article I just published for the Journal of EMS a couple weeks ago, about this idea of ecosystems building bridges among one another. And it is absolutely emerging. There is a bottom-up group. Won't talk about it too much right now, but I'd invite anybody to join our group. It's the Unity, Diversity, and Optimism group for a vision of the future of fire and EMS on both Facebook and LinkedIn. And I've been one of the people, one of about 300 who have raised our hands and say we need to start building these bridges. And folks are really starting to do that because they're realizing that none of us is alone in this. And that is a compelling realization. Mobile medicine is part of public health. There has been, a long-standing lament of the idea that EMS is the redheaded stepchild of the healthcare system. Some of that is the EMS industry putting it on itself, but that's a topic for another time. At the same time, police officers have been enormously hit by the coronavirus, and not just in New York. In New York, it was double-digit percentages, something like 17% on one day. April 1st were described as having been out sick, one way or another, exposed or confirmed to coronavirus. The New York Fire Department's fire union estimated that about 25% of its EMS personnel called in sick in a single month. If you can think about the New York City Fire Department's department, but besides being the largest in the country, is the size of a small city. So to have 25% of your people on just the EMS side, which again are the ones going into the homes and providing the medical care to those who need it most, who can't get to care on their own, that is an absolutely enormous hit. And so we've been hit as an industry with a fascinating dichotomy. On the one hand, before all of this crisis was going on, the COVID crisis, mobile medicine had its own crisis, under-resourced, lack of attention, again, this internal fracturing of different factions and who gets what budget. And so you saw headlines from places talking about how the demand is so high and the resources so thin, especially with all the healthcare issues that existed before COVID exist today, right? I mean, chronic disease, substance use disorder, loneliness, which, by the way, was a huge driver of chronic disease and premature death before COVID-19, and of course, with all the sequestration and quarantine, is made even worse now. All of those existed before, but now we have a different problem. Now people are afraid to call someone to help. Nursing homes that have been keeping emergency responders actually coming in not for a routine transport, but an emergency medical response, and they're keeping them at the door from Connecticut to Florida. Places all over the country have been saying, you can't come in here, we have to bring the patient to you. That's a problem. How does an industry that is still today, by the way, paid as glorified taxis, paid by the mile in this country, which most people don't know, mobile medicine, despite all of its professionalization, its enormous qualification, and the fact that they are the ones you call when you have nobody else to help you, is still paid by the mile. So if you are taking care of a patient and not transporting them because they're afraid to go, you don't get paid for that call. If you're afraid to call, you don't get paid for that call. So who is there to take care of the community when the community's most critical resource during that crisis becomes insolvent? And again, that's a business problem, but it's also a political problem, a legal problem, a healthcare problem. We have to deal with that. And so I really wanted to call out one wonderful example. A lot of people here know Josh Watts. Josh Watts is the CEO of MedTrust, which is a emergency and non-emergency medical transport organization in 3 states in the Southeast, 3 of the hardest hit states, as you will note, South Carolina, Georgia, and Florida. And in April, as this was just getting underway, he put out a video that I beseech everybody to watch, where he reminded the world that hurricane season is not yet upon us, right? So it's just getting started. We're in July. These organizations are the ones who are also going to be called to help with hurricanes and tornadoes and fires, in addition to flu and the mixing of flu with COVID. And so we really need to remember that as goes mobile medicine, so goes public health. I hope that's a bold and underlined takeaway from today's conversation. And so we really need to understand what the needs of the mobile medical professionals are. And so I'm going to segue here to talking about the case studies. The work that we have at Beyond Lucid Technologies have had the pleasure of doing is really interesting in that we took a technology, for longitudinal tracking of patient care. So that means tracking of patient care over time. In mobile medicine, most encounters are considered episodic or incident specific. So they are essentially somebody calls 911, or somebody has a scheduled interfacility transport, someone needs to go to dialysis. There is an encounter, there is a movement of a patient, there is a handoff of the patient, there is follow-up with the patient or the institution. But all of that is contained within the context of an encounter. So that is an encounter that can be bookended. You essentially have a start and you have an end, and then you have movement of information in one direction and movement in direction in the other direction within those bounds. Through the Affordable Care Act and others of contexts around that, there has been a move toward longitudinal care. So taking care of patients over time who have either chronic disease, things like heart disease, congestive heart failure, COPD, advanced diabetes, who are at a risk of falling down, who have been discharged from a hospital for something like surgery and need follow-up care to make sure that they don't have an adverse reaction. And now there is something that I've been referring to as community paramedicine 3.0, 2.0 being a data-driven version of the program I just described, 3.0 being a focus on the acute cases, specifically acute recidivism associated with overdose and substance use disorder. And so that's what we do. And we essentially help that information be tracked over time so that you get a picture of the person's health over an extended period, 30, 60, 90, 180, 365 days. And one of the organizations that we worked with is Cypress Creek EMS in the northern part of Houston. So it's in the Houston metro area in Harris County. And I get a call from Christina Dubois, who you see here, on March 13th. And Christina is one of the most forward-thinking innovators in this industry who will never take the credit that she deserves. She's incredibly humble. She's incredibly good at what she does. And she basically said, I want to put my care providers, my personnel, into a community paramedicine tracking program. And I had no idea what she was talking about because personnel are not generally in that type of longitudinal care. That's for the patients. I said, it's not a staffing program. What are you trying to do? And she explained to me what you see here, which is that these care providers were going out and seeing patients who were calling with chest pain and breathing issues and all the other symptoms associated with COVID, but also those not associated with COVID, and they didn't know the difference. And so the providers themselves were getting exposed to coronavirus. And this was before everybody was assuming every call was a COVID call. And so everybody was wearing full PPE and so on and so forth. And so she said, I want to put my personnel into this type of tracking program. And that was by absolutely the most brilliant thing I was going to hear all day. And so what she ended up doing was just that, and tracked her personnel over time. Basically, this is a period of about 6 weeks that you're seeing, 5 weeks that you're seeing here. And what she did was she inverted the community paramedicine technology, the longitudinal tracking program for her patients, and she applied them to her providers as patients. So what she did was, again, tracked things like their symptomology, the medications that they were taking. How are you doing today? Who have you seen today? Have you traveled? And if so, where have you traveled? And rather than look at this as an episodic encounter, just a one-off interview, what she did was she started saying, tell me more about how you feel today relative to yesterday, to the day before. And so over 7, 14, or 21 days, she essentially became the first organization in the United States to apply a community paramedicine technology to her own personnel, inverting the program on itself, on her own department. An absolutely unbelievable example of innovation from the ground up. It was not my idea. And that's why I always want to make sure that we give credit where it's due. What Cypress Creek did set a paradigm for others, even in their own community, but others elsewhere in the country. We'll get to Los Angeles in just a second, which, you know, by leaps and bounds bigger than Cypress Creek EMS. So on the left here, what you see is a critical example of the realities of mobile medicine, and this is where mobile medicine, but also I'm going to include in that public health, public safety, policing too, because again, I don't think there's enough focus, and I've tried myself to get inroads into the police and corrections communities, and it turns out it's a hard ecosystem to crack. But the show must go on, right? So all of the work that Christina and her team were doing around focusing on high utilizers of EMS, the homeless, folks at risk of falling, folks who have chronic disease, and so the other members of her crew referred into this managed care program, those all have to continue, while at the same time now blowing out the sheer number of patients that are being seen in this type of program instantaneously. And those personnel, the patients, are the personnel in her department. They are her colleagues. So you've got all the considerations around HIPAA. You've got all the considerations around the human function of explaining to somebody that they have this virus, which might go away or might end up killing you. And that is certainly a mental health stress. But there is also the dynamic of the fact that these are folks who are working and not necessarily only working one job. They are going home and they're seeing their families. They are going to a party with people that, you know, all it takes is one person coming in who turns out isn't taking this seriously. And so a quote here on the right from Joe Cassiotti, who's the battalion chief of community medicine at Harris County Emergency Service District 48, on the other side of Houston from Spring, where Cypress Creek is, saying we've had the challenge where we have people in his department who work elsewhere, right? They moonlight, or they have second jobs, or they teach, or they take care of families, or they go shopping at Costco, right? They do whatever else they're going to do, and there is no way to know when someone walks into your door what exposure they've had elsewhere. So the idea of relying on someone else to do the right thing in terms of keeping your own people safe is not tenable when you're planning for the worst. And so this is where, again, to those who have figured that they're going to simply find their way through and deal with it as it comes, they may find pretty quickly that they can't do that anymore. And there are innovators in our industry, in our communities, who have really taken it upon themselves to say, yeah, we're not going to wait. We're going to put stuff in place now. So Los Angeles County, I promise I would show this. I mean, there are so many things that I can say about LA County, and I'm just going to try to highlight several of them, or a few of them. 6,000 plus people in the department. Again, there are towns that are smaller than that, and not a few of them. It's so big that they use a two-tiered triage structure. So essentially their approach has been first to do essentially a sifting through of calls for PPE to make sure that everybody's using the PPE appropriately, that the PPE is holding, that something didn't break, that something didn't get breached, essentially, they're assuming that every call at this point involves some kind of potential exposure. So the first pass is this PPE report form. Based on that form, they score the encounter. And so if the encounter goes above a certain threshold, they essentially put them into this monitoring program, and then they triage them within the monitoring program. Low risk, medium risk, high risk, sent home sick, return to work, hospitalized, and so on and so forth. Their volume is so high that they're at a 60,000 annualized an annualized post-exposure monitoring form volume today. So again, 60,000 runs, encounters for EMS is a pretty significant volume anyway. This is 60,000 people monitoring post-exposure. So they've had a high enough exposure that they're put into this program. And that's just at 3 months. They have 75 hospitals across the county, all of which are now able to receive EMS data in real time through a partnership that we had with their electronic patient care record provider, Stryker Corporation. That was established within 24 hours. And the reason for that was quite simple. There is a possibility that any one of the people, of those 6,000 people inside the department, may need to be transported due to symptoms that have developed from COVID-19. And so we needed collectively to ensure that any hospital in the county that would receive any one of those providers as patients or support team members as patient could be able to receive that data and give back information about their outcome, whether or not they were in fact positive. So this is a picture of one of the members of the health programs office doing the heroic work that they do. Now this is where, again, I want to make sure I highlight the good and heroic work of other people. First of all, for the math junkies and geeks on this phone, remember, we're looking here when we talk about flattening the curve, not at the real number of exposures. The real number of exposures is going to go up. What we're looking at is the derivative. Right, we're looking at the slope of the line and trying to flatten the slope of the line, flatten the curve, as it were. In Los Angeles, as of yesterday, so the screen on here is a bit old, this screenshot's old, but as of yesterday, the department has about 55 people in isolation out of 6,000 people in the department. That is a tremendous job, right? It gives them an exposure rate or a sick out rate of approximately 0.9% against a statewide positive rate of over 7%. So an enormous amount of work has gone into ensuring that they keep their own personnel safe. And what the department did, again, kudos, this is not me. I provided the data system. I didn't do the work associated with understanding what the data mean here. The emergency medical service team and the medical director's office in particular at LA County Fire deduced a heuristic algorithm for triaging patients in the absence of tests to determine whether they are likely to test positive. Think about that. So in the case where you don't have access to a test, they found patterns in the data that allowed them to determine whether or not you are likely to test positive. So think of this like a COVID version of a pregnancy test, right? A pregnancy test doesn't tell you that you're pregnant. It tells you that you have a high likelihood of being pregnant. Therefore, go to a doctor and have the doctor do a formal exam to determine whether or not you're pregnant. And so that's essentially what the medical director's office at LA County Fire did. And it has been holding so remarkably that while they do have false positives, and there are people who are essentially being tested and being suggested that they need to get tested who turn out to test negative. So the algorithm is essentially over triaging and saying you might have an issue, so go get tested. It has to date had a 0% false negative rate. 0. So what that means is no one is getting out of the net, right? Nobody is getting sent out to work and potentially exposing others when they have come through this process that LA County put in place and found to be high likely positive. And that's really where damage tends to happen, right? Is when you send somebody out who's sick and you didn't think they were sick. We talked about Outbreak, right? Outbreak, the movie, is all about that. You let a monkey out and the monkey infected people, and the person who thought they were okay and went home infected his family members, and off it goes. And LA County has had zero of that. So that data emerged from their processing of the longitudinal and counter information about these patients that they put in place in 5 days, by the way, 5 days for a 6,000 person organization. This video, which I'd be happy to make available to anybody, and I can put it in the chat, or Krisha, you can send it out, is really a remarkable first person account from Terrence McGregor, who you can see his credentials, but he's the coordinator of the Health Programs Office COVID-19 Response Center for Los Angeles County, talking about what this has meant to them.
So I think to start with, it's important to understand that we recognized very early on of the potential for the pandemic to significantly impact our first responders. And we've seen those impacts in other agencies across the country, in New York City and Chicago, just to name a few. We've seen rescue squads in New Jersey shutting down because of the impacts on their responders. So we knew that there was a potential for the coronavirus to take down, quite frankly, a significant number of our personnel. Fortunately, to this point, that has not occurred. A lot of credit has to go to our organization's logistics team in securing adequate PPE. But the reality is, in having to evaluate potential exposures, people who become ill at work, we needed a plan in place that would allow us to monitor the well-being of our personnel, to intervene appropriately, to test personnel who were symptomatic, those around them who potentially were not, and then to evaluate that information in real time and be able to act appropriately and quickly to any exposure or illness. And so couple of things that we identified early in this process is that our existing capabilities were going to be inadequate. Quite frankly, like many organizations, we had an exposure reporting system that was built to deal with needle sticks that occur infrequently, not dozens or potentially hundreds of daily encounters with a novel virus. And all of this data is able to be incorporated into a longitudinal platform that serves as a medical record for potential workers' compensation claims or other benefits that the employee may be entitled to as a result of their occupational exposure. So spreadsheets serve two purposes for us. They serve as a way to communicate amongst our team who are, like many people, working remotely from their homes primarily, who are performing their functions. And so, we've got a cloud-based service that allows us to keep our daily workloads, personnel that we need to contact because they're ill, follow up on who need monitoring, scheduling testing. That data is maintained in a workbook so that we've got some continuity from shift to shift, day to day, and throughout the day, and we can see those updates in real time as we're working towards our common goals. We also use that to evaluate trends in the organization, where exposures have occurred, to follow those exposures, especially the workplace exposures where we've had ill personnel at work. So it serves as a platform to track our taskings and to evaluate our data. Fortunately, we're not trying to log, thousands of lines of data from exposure reports on the spreadsheet and make sense of that, because we've got software that does that for us.
So it sounds to me like you're saying basically the spreadsheet component is being used and effectively for sharing and processing data that you've already captured. So,
for the most part,
on the backside.
Correct. We do use our spreadsheets as well to, on the front end, to as a communications tool more than anything to know the personnel that we need to pay attention to that day, so that when we go into the health record system, into MetaView, and look up that information, that we know where we're supposed to begin the day. If we were using notebook and paper and Google Sheets or Excel to manage that process, it would simply be a full-time position for somebody. And in the midst of a pandemic, you know, on a small organization where all of your administrative roles, or nearly all of your administrative roles, are also collateral duties for field personnel, that's not practical. And so on the small scale, it makes the job much easier to automate the tedious work, the 80% of the job that a computer can do and doesn't require an individual whose talents can be used elsewhere to sort through what essentially is noise at that point, to get to what they need to determine is actionable information. When you're talking about an agency on the scale of Los Angeles County, where we're monitoring on any given day dozens, if not hundreds, of personnel for exposures, it's just simply an overwhelming task, and would require an army of clerical staff to do so.
I want to talk about why this matters, because the letter on the left is from Delta County Ambulance District in Colorado, which represents far more of the United States than does Los Angeles, right? And in this small town, whose EMS director, by the way, was named EMS Director of the Year for the state of Colorado last year. So Kirby Clark and his team know something about doing EMS well. They can't get tests. So they're fairly certain that they have positives in their community, but they can't get tests to demonstrate it. And in Los Angeles, that's starting to happen as well. So the idea of having an algorithm that allows them to suggest who really needs that, or provide the justification to get the resources they otherwise might not get, it could be a huge boon to parts of the country that are feeling the pinch as this wave grows again. And so I wanted to make sure that I highlight here as we segue to the idea that others are going to need this information. On the left side of your screen here, you're seeing the first ever debut of a case study involving an interface between my organization, Beyond Lucid Technologies, and emergency reporting, which is the second largest fire records management system used in the United States for records for fire documentation. Pima County, Arizona, the Tucson area, called me, the health department called me a couple weeks ago asking about contact tracing and asking about the ability to share data. And I'm particularly proud because I know that Chief Amezaga is on this call right now, and I want him and his team to take a bow, again, far more than they would on their own. There's a lot of humility in our industry. Not only were they able to share data with Pima County and their own county, which is, by the way, Pima County is Tucson. They are not in Pima County, so they're crossing lines and able to share data there. But we were actually able to show the hospitals having access to the data right now. So the screenshot that you see here, which I'm going to blow up a little bit just so everybody can see. Can you guys see my screen? I'm assuming everybody can see my screen.
You can see it.
Perfect. So this is actually from Banner University, Tucson. And what you're able to see is data from Rico Medical and Fire District showing COVID exposures, COVID symptoms, COVID confirmations, and so on, as they were being transported to the facility. And if this wasn't a confirmed exposure, if it was someone who had pneumonia but did not have that, the hospital, with a single touch of a button, confirm COVID-19 diagnosis, can actually send these data back to the agency so that they know now that we need to go to this person's home wearing PPE because they've been suspected of exposure. This is immediately relevant because there's a lot of controversy happening right now around what rights to access and what should people share. Texas, Florida, California, there's been a lot of conversation around whether or not you should be providing information to those emergency responders around whether if someone in that home has tested positive for COVID, and whether that's a violation of privacy, HIPAA, et cetera, et cetera. What the Rico Medical and Fire District and its colleagues at Banner University Tucson have demonstrated is you can share that information in a HIPAA-compliant fashion. It's secure. There's no name. The emergency responders know which record it is because there's a patient record number generated for that encounter, right? But there's no name. So the people who need to go out and see this patient again and stay safe in doing so have the ability to keep themselves and their people safe while doing their jobs and protecting the patient's privacy. And so that said, in the last couple minutes here, I'm just going to show a bit about the how. And by the way, I want to congratulate all three of these departments, the two departments in Harris County, ESD 48, Cypress Creek EMS, LA County Fire, and Rico Medical and Fire District for being really an enormous and wonderful demonstration for our industry around, again, real-time innovation in a critical context, and they themselves represent the gamut, right? In Harris County, you've got suburban areas, you've got certainly urban areas, some are urban than others. You've got Los Angeles County, which doesn't get a whole lot more urban than that. And then you've got Rico, which is about 6 miles or so from the Mexican border. So they are definitely more rural and net representing that they can, again, be a partner, like we saw that twins shot earlier, small company, large organization, like in our case, or small organization, Rico with huge university hospital Banner. And again, the innovations sometimes come from places you don't expect. So just a couple screenshots here to show you how this worked. Essentially what we did, and this is Los Angeles County Fire's form, which is an actual form, which we have adapted as well to to other cases outside of Los Angeles. And essentially what they did was they are looking at the symptomology and the interventions that the patient, in this case the care provider as patient, have done to remedy what they're experiencing. So over a 7, 14, or 21 days, when were you exposed? We're using their employee ID number. This was a really, really important step that we took. Notice there are no names on this form, just like we mentioned in the last slide. This is not a HIPAA compliant form. We did not want to utilize a HIPAA compliant form because that requires things like passwords. Right, so if you have to log into something, it puts a barrier to adoption. This form is a simple web form. It's basically a glorified Google Doc or some other spreadsheet that you use on your phone. And you can fill out in about 30 seconds how you're feeling, when you're testing, what day of your testing protocol you're in this case, numbers 1 through 21, temperature, medications, symptoms, and so on. And what we do is we utilize this employee ID number and we tie it to a roster that we maintain for all of the personnel in the department. So you might have seen that on an earlier slide. I mentioned that in Los Angeles County we got started in 5 days. And one of the reasons we were able to do that, again, A, we didn't need everybody to memorize a new password, and B, all we needed to do that was a roster. We use that roster to create patient profiles, just like we would talk about in this longitudinal chronic care management program, where we essentially generated a profile that follows the patient over time. And what we've done is mapped the elements associated with the medications, the symptoms. We're talking about RX norm codes, ICD-10 codes, etc. So they are HL7 interoperable. They are consumable by electronic health records, by public health systems, by epidemiological tracking programs. We've got a couple in our industry. Heads up, high five to First Watch and Biospatial, and some of the other Juvare, some of the big analytic programs that crunch this big data. They can suck in these type of data because they're standardized. But we made it so easy for the provider in the field. It only takes about 30 seconds. They can do it on their phone. They can do it on their iPad. They can do it on their computer if they're sitting at a desktop, whatever it is. And by mapping those through, we automate the collection of the data in a fashion that is deceptively simple, because there's actually a ton of stuff happening behind the scenes to map those data elements to the patient record system that will aggregate the data over time to ensure that individuals, as they move through your program, are assigned to the appropriate monitoring cohort. Whether you are, again, are you a low exposure because you wore all your PPE but the patient coughed, Or are you a higher exposure because you caught the virus from a colleague of yours while you were eating dinner next to them inside the fire station or the EMS station? Or because your PPE broke, or you had a needle stick that exposed some of the skin, and so therefore, things were able to get in, etc. So all of the monitoring cohorts are automated, and they aggregate to the patient over time. So if I were to click this little view past trips button, what you would see is a list of all of the encounters that we had with this personnel, this provider as patient, seeing the evolution of their symptoms over time, just like you can do for a chronic care patient, where you can see how has their weight evolved over time. If they're a CHF patient, are they retaining water? What have their vitals looked like? How has the range narrowed or widened? Are they adherent with their medications? These are all things we do for chronic care and for substance use disorder patients, and we're applying the same approach to the patients to your providers as patients who may have been exposed to COVID. We utilize templates to bucket these patients into specific groups of symptomology. So again, if you're looking at, say, pneumonia or bronchitis, acute respiratory distress, gastrointestinal, have you traveled, et cetera, et cetera. The reason for doing this, of course, is because when you go to do your analytics, if public health doesn't have accurate data captured from mobile medicine, how are they supposed to understand what's actually being encountered in the field in real time? And this is one of the big topics in public health epidemiology conversations right now, lagging indicators, right? So if your data are old, then your insights are old, then your reactions are already out of date. So the idea here is that by restricting and constraining the questions that are being answered, or the answers that are being provided, I should say, to things like COVID with pneumonia, COVID with ARDS, then you don't have to require the mobile medical professionals to try to remember which item on the drop-down list am I supposed to select right now, which is a huge problem in mobile medical documentation. There's so many choices. The ICD-10 list, this is the same thing for folks working at hospitals with their EHRs, which, by the way, EHRs are the only technology and health technology more hated than electronic patient care records in mobile medicine. There's simply too many choices. But the problem is, if you don't choose the right one, you have bad data. So what we've done is we've helped them drive down to the correct choice. And these are being driven, as you can see here, by the Emergency Medical Services team and the Medical Director's Office at Los Angeles County Fire, which is affiliates to places like UCLA Medical Center and the USC Keck School of Medicine. And so we're really trying to bring a very high level of clinical excellence, clinical expertise to this process, while also ensuring that the folks who need to get at the data have the ability to do that. And with a simple touch of a button, they can provide the outcomes that mobile medical professionals so desperately want, that public health needs but can't generally get in a timely fashion, and kick it back to the source agency so that they can close the gap, they can ensure that their providers are safe, that they are utilizing the PPE when they go out to the home, that they are ensuring that the personnel who need to go home, et cetera, et cetera. And so really about closing the gap using technologies that were already in the wild, so to speak. As Krisha so graciously introduced, almost 200 hospitals already connected to this network for sort of everyday communication between mobile medical professionals and the care facilities that they work with and the public health agencies that ultimately need to consume the data. What we did here was we put a turbo into that tank and applied the clinical documentation requirements associated with COVID in a fashion that was so easy to use that LA County could teach its providers how to utilize this in a span of 5 days. And so this is my last slide here, going back to where we started. If LA County, with a population in its fire department alone of 6,000 people, can utilize a technology in 5 days to flatten the curve, what could we do if we applied this similar technology in other sectors There's been a lot of conversation lately about the use of this type of technology in schools. If all we need as technologists, for example, is a roster, I know what students are supposed to be there. I know what teachers are supposed to be there. I have a manifest from your airline. This is what the CEO of Delta was talking about when interviewed about the infections, the confirmed infections that they had among their passengers. They used a manifest to do contact tracing. You have the same thing in cruise lines, right? Sporting events, not necessarily all of the attendees, because you're not necessarily going to know who everyone is, but how about the staff? Turns out that my next door neighbor works for the San Francisco 49ers. We've had this conversation several times now about how many people in the organizations that encounter these folks. You know who they are. You know who the staff is. Basically, anybody walking around an office with a badge on, you know who they are. So if you have the ability to know in a warehouse who was on shift that day, who did they stand next to on the line, who did they have lunch with, what we've done, and again, the kudos to this goes to the personnel, the departments like Cypress Creek and LA County, New Britain EMS, which is also on the call here today, and Rico, ESD 48, who have said, this is what we're going to need in order to put a ring around our department. This is what we're going to need in order to bound our potential universe of exposures. I know which personnel were here, I know who they worked with, and I know what patients they saw. Same thing in a jail, right? Which personnel saw which people? Who had a visit from someone on the outside? Who are they living with? If we can apply this method to these various areas, if we believe that this virus is going to be here for a while and is going to spur some next thing, there's going to be another emergency. If we take this user-generated approach to contact tracing and apply it to both public health and public safety, could we utilize that to inject a process into so many industries that we truly have the opportunity to flatten the curve across the gamut, get people back to work because we understand how to do this in a way that has already demonstrated success. So I'm not bringing this to you as an idea. I'm bringing this to you as an example of things that are already being done at scale, and looking forward to where else we can be helpful, and hopefully inspire others to utilize. So I know I've talked a long time. Thank you all for being here with me and for hearing some of these wonderful examples of people who've done some remarkable work in a very short and very stressful amount of time. My contact information is here. I'm happy to take any and all questions now if you have time. And again, thank you so very much.